Okay. What I want to talk about briefly is that um, we are going to plan on having the final on Monday. And what I'm going to do is the same thing I've been doing. Um, we'll talk a little bit about today about what I was looking for on this last test, anesthetic emergencies and CPR. And then Monday, I figured we could review because the sections on the final are going to be bovine, swine, exotics, and anesthetic emergencies. And you can get in and you should be able to look at your old tests. I believe I still have them open for viewing. So you'll probably want to go back and review those tests. Um, but we can also talk on Monday, go over some of the big problems that were on those tests. And then I think I've emailed everybody and say something here if you haven't known. What I'd like to do is next week on your Tuesday, your Wednesday, or your Thursday, we will meet in 115 at 1 o'clock and can go till maybe about 2 or 2:30, maybe 2:30. And I'm going to go through a machine, set it up. You can fill a cuff. I have a way to set up a machine where you, sorry, you actually can bag, make like a fake patient. So you can practice with the pop-off, practice squeezing the bag. I have gotten some feedback. My question this week was only, what do you want to review next week before surgery rotation? So most things I got were machines, reviewing the pop-off, the breathing systems, and drugs. So those are the things that I plan on covering. And then I have a checklist that I will give you that will help you, be familiar. And what I've kind of told people that I've seen in the hall is the checklist is designed to tell you everything you should know how to do. Now, obviously, you haven't done a lot of these things. I mean, are you going to walk in and ace intubate your patient day one? That takes practice. So, but understanding the principles of what your job is supposed to be, having some kind of a cheat sheet on monitoring values. Sorry. It's not the Rona. Oh, good. Caleb, that's good to hear that she gave you. That's good. So maybe bring that with you. Nobody is going to care that you have a nerd book, a cheat sheet, notes written on your clipboard. It's not like you're expecting to have this memorized by any means, but you just need to be familiar with what you need to do. So my checklist, hopefully with her cheat sheet and stuff you've done, will give you a good prep for, starting rotation in a good way. So I'll just plan on seeing you guys on your Tuesday, Wednesday, or Thursday next week, and then we will plan on Zooming. We'll review Monday, and then the test will open after our Zoom, like I've done before, and it'll be open till Tuesday at, probably it'll have to be done by 1 o'clock because there's going to be people. Normally I have it go until 2:30, but we're going to have people coming into our class. So we'll see. I'll let you know about that. Okay, so let me just go ahead and talk about this anesthetic emergencies test. And like I said, I have to get these finished grading, but just if you're remembering the test in your head or, the big thing was the reasons for the problems. The four main reasons were the equipment failure or human error, adverse effects, and then patient factors is the patient has a risk factor. And obviously, the first thing I focus on is human error, because that's something that we can control by being prepared, understanding. I think my question was 3 examples of human error, miscalculating, drawing up the wrong drugs, not being prepared, not paying attention, not hooking up the machine properly. So, I have a lot of students that want to review the machine the day before they have surgery. Now, I think I've mentioned on a side note, and I don't know if I've told everybody, I lose track of who I've talked to, but I'm not in the building next term. I'm online completely. So students used to grab me and say, can we go over a machine? I have surgery tomorrow. I can always set up a call with you. I can always, and there's a potential I could arrange to be in the building to help out, but hopefully I'll answer all those questions next week, because I just won't be there. Okay, so there was a question that said sevoflurane can be used in either vaporizer, and that was false, because the dental machine you guys will use is Sevo. The surgery and the prep room, the surgery prep table, are isoflurane. So just make sure to not mix them up. Purple is iso and yellow is Sevo. If you do accidentally put it in the wrong one, you absolutely have to tell someone ASAP, because that vaporizer have to be sent off for service. So make sure you let somebody know if for some reason, you think you put the wrong one. Just pay very close attention to that. And if you remember why, sevoflurane has a different vapor pressure than isoflurane, and the vaporizers are temperature controlled and pressure controlled. So they are calibrated specifically for the agent. So they are not, if you put Sevo in an iso vaporizer, you can run very dangerous levels to a patient. So that's why it's very critical that you do pay attention to which one you're using. And then I had, which is not an example of human error, which was pediatric patient. Obviously, it's got nothing to do with you, but a bad vaporizer setting, expired soda lime, or improper tube placement. Those are all things that are our fault. Why must the pop-off be open during anesthesia? So I've gone through a few of the tests, and one answer is that if it's closed, they won't receive oxygen. So the pop-off doesn't have anything to do with the oxygen flow. So when the oxygen comes in, it comes in through the inhalation valve. When the patient exhales, they go out the exhalation valve. And so when they go to exhale, the exhalation valve has to be open, but because what would happen was pressure would build up. Because when they exhale, some is going to go into the rebreathing bag, but a good amount is going to go out the scavenge. The pop-off valve closes off the scavenge. So therefore, all of the gas is between the patient and the machine. And you have oxygen flowing continuously, so pressure is going to build, build, build. So it's really, you don't want to blow up your patient's lungs, or the fancy way to say that is you don't want to cause barotrauma. And barotrauma is where you overinflate the lungs and you cause damage to alveoli from overinflation. So that's your concern. Is it safer to use one agent to pre-med? And that's never correct. If you only use one pre-med by itself, you have to use much higher doses. You see much higher side effects if you use higher dosing. So if you use multiple agents, which is called balanced anesthesia or multimodal analgesia, everything we talked about, my making soup analogy, is you want to use multiple agents so you don't have to use as much of one drug. So in the matching section, which I think was fairly self-explanatory, neonates, our big concerns is, now these are patient factors now, so low body temp, low blood glucose, not full organ development, and this is usually 4 months and under. Like AJ's 4 months, so he's kind of right on that border um, but kidneys are still developing when they're under 4 months of age, liver, and so I just use low doses, keep them warm. Also, fasting um, may have them eat later in the evening, and always maybe check a blood glucose before surgery, make sure they're not hypoglycemic. Geriatrics, poor stress response, poor prolonged recovery. Now, age is not a disease. I've had a lot of old patients do really well under anesthesia, but we do worry about their liver function. Their liver is older. You're obviously going to check blood work, but you're still cautious, and they usually have decreased muscle mass. As they age, their muscle mass goes down, so they can be colder after surgery. So we want to keep them warm, use low doses. Obese patients, you have to calculate drugs on their ideal weight, but the answer on the test was hypercapnia from shallow respiration. So they just tend to, all that weight that's pushed on their diaphragm, they actually can hypoventilate, or they do these short, rapid breaths, but they don't breathe deep. So hypercapnia is elevated CO2. And they can be they don't ventilate well on their own, so you have to assist them more often. Brachycephalics, obviously airway compromise, small airways, prone to dyspnea, sighthound, sensitive to most pre-meds and anesthetics, cardiovascular disease, prone to hypotension and arrhythmias. Hepatic disease was altered drug metabolism, and low protein. Don't forget, anytime a patient has liver disease, metabolizing, we have to worry about metabolism of anesthetics. But the liver makes clotting factors. The liver makes protein. So the big thing I worry about is that, do they have a normal protein, which they need for fluid therapy, which they need for drug binding, and which they need for tissue healing. So anytime a patient has altered liver enzymes, you always have to be conscious of their protein levels, clotting factors, and use low doses. And then cesarean section, blood pressure is vital due to compressed organs, blood flow, patients often debilitated. So, a lot of times the mother comes in, she's been pushing. Maybe they weren't giving her proper nutrition. Maybe she's just been in labor so long. Sometimes they're vomiting, they're dehydrated, they're not eating. So they don't come in the greatest of shape for a C-section. So, and we have to, I didn't put anything on here about the pups, but we have to watch what anesthetics we use before the puppies are taken out. After we remove the last pup, we can usually top off or give the mom some good analgesics. We can usually do that. Which is not a concern when anesthetizing a trauma patient. Narrowed airway was the correct answer, but pneumothorax we worry about. Arrhythmias due to a bruised heart. Hypotension because they're often in shock. Arrhythmias happen, if you think about a hit by car, the heart and the lungs get jostled. Potentially you can have a leaky lung. That's where the pneumothorax comes from. Or you get a bruised heart muscle, which is going to cause arrhythmias. So, low blood pressure, you should never rush into surgery with a trauma unless like an organ is like if the spleen is bleeding because they got ran over on their belly, obviously we have to go into surgery. But remember, they're not going to die from a broken leg or they've got some scrapes. Wait till the patient is stable to do anesthesia after a trauma. List one way you can pre-oxygenate your patient prior to anesthesia. And this is something that I don't think I stressed a lot in lecture, but if you have a patient you're concerned about, especially a brachycephalic or a trauma patient, or a patient had trouble breathing, or they're high risk, if you give them 5 minutes of oxygen right before induction. So I pre-med them, put them away, get all my stuff set up, get my fluids, catheter, endotracheal tubes, anesthetic record filled out. Then I get the patient out, and if you have help, you can do it while you're putting in the catheter, but I usually put in the catheter, and then right before the propofol, I give them 5 minutes of oxygen. And that can either be hold the tubing in front of their nose, which is called flow by, because it's just flowing by. You can put a mask on their face, but I have a lot of patients that don't like the mask. They feel like they're being held. Remember, I've said in the past that black ring around the mask comes off, and you can just put the clear cone in front of their face, and it doesn't constrict their muzzle. If you're watching me, you're seeing what I'm talking about. But you can put that in front of their face. You could put them in an oxygen cage or like an e-collar with oxygen piped in. So, and again, it's beneficial to pre-treat with oxygen. What is one reason you should not rush into anesthesia after a hit by car, which I just explained? You need to assess them, make sure there's no arrhythmias, make sure the patient doesn't have a pneumothorax, check their blood pressure. So again, the only time we've rushed into surgery is usually if we have proof that they're actively bleeding into their abdomen, or potentially a life-threatening pneumothorax where we actually, have to take out a lung lobe. But most of the time, some of the trauma problems can wait till you get the patient stabilized. Then they're a better surgery candidate, a better anesthesia patient. 2 ways to treat hypotension during surgery. So there was a kind of a step-by-step in the PowerPoint. And this is important because probably one of the number one problems that I deal with, which drives me insane during anesthesia, is if I have a patient with a low blood pressure, which is hypotension. Because a lot of the drugs that we use drop blood pressure. Now, it may drop it from where it was and it's still in normal range, but if we have systolics below 100 in a cat, below 80 in a dog, and if we have means below 60, that's when we're getting to hypotension levels. So if you're getting close to those numbers, or you're at or below those numbers, the number one thing I do is I turn down my isoflurane or my sevoflurane, because they're probably the most hypotensive agents we use. The higher you run on those gases, the worse the blood pressure is going to be. So I said in my lecture, my recorded lecture, if you're having to have a patient upwards of 2.5, 3, getting up to 3.5%, that means your patient is feeling something. And that means that you need to do something to maybe give them some pain meds. Okay? Because if you keep having to turn them up, why are you turning them up? They're reacting to the surgery. And why are they reacting to the surgery? Because they're feeling something. Well, why are they feeling something? Because they hurt. Why are they hurting? Because we didn't meet their analgesia. So when you turn up isoflurane, you're just masking the pain. Remember, iso is not analgesic. It just prevents them from moving. So the number one thing to do is turn down your gas. The second thing you can do is give fluids, like a fluid bolus. Now, you'll be running fluids during surgery at what's called surgical fluids. But this would be like for maybe 5-10 minutes, double the rate, or turn up the fluid pump to 999 and give 50 mils. I mean, you would have to ask your doctor how much fluids they want to give. I usually say, how much do you want me to bolus? And they'll usually give me an amount. And when I say bolus, usually we set the pump to deliver it as fast as possible. And that gives you a boost vascularly and hopefully boost the pressure. The other thing, the last thing we would get into, like positive inotropes, which are drugs like dopamine, and that increases vessel tone, increases blood flow to the kidney. Um, but usually I can treat it by doing one of the two other things. Which of the following is not a reason a patient may not stay adequately anesthetized? Um, yes, actually, make sure, Caitlin, you remind me. She just typed a question. Will we have a fluid pump during surgery? You will have a fluid pump in surgery. So I don't know if you went over that in Tech 4, how to set up a fluid pump, but I can show you. The fluid rates are in your surgery notes, in your surgery packet. Um, Make sure you calculate the proper fluid rate if you have a dog or a cat. And remember, there's different drip sets for dogs and cats. So you have to make sure you use the proper drip set and you choose the proper fluid rate when you guys do, because a lot of students do the wrong calculation. They do for a dog and they have a cat. Yeah, Kaylin, let me put a note. Fluid pump. Trying to make myself a little to-do list. Okay, we'll go over that. So the reason that they don't, or the reasons they do not stay asleep, their endotracheal tube might be blocked. Okay. A vaporizer may be malfunctioning. So say somebody knocked it over, or something happened to it and it's not delivering the proper amount of anesthetic. A leaky anesthetic machine, maybe you didn't leak test it, so your anesthetic is leaking. You guys, this is a very common thing you'll have to troubleshoot, is why is your patient getting light during surgery? And it's not always that the patient is just painful. Why is there a reason the patient isn't getting the proper amount of anesthetic? I'll tell you a little thing. My friend works in Anderson, and we belong to an anesthesia group on Facebook for anesthesia techs. And she posted that they were having trouble keeping patients asleep. They had the company come out and check their machines, but they checked the temperature of the OR, and the temperature in the OR was so cold, it was affecting the temperature of the vaporizer. So the vaporizer wasn't delivering the proper amount of anesthetic because the room was too cold. So they kept having these patients getting light, and they checked their tube, checked their machine. The only thing that they cannot do is you usually have to have a company come and check your vaporizer, because they have a little machine that they can hook up to it that will tell them the percentage it's delivering. And we don't usually have that machine. That comes from the company, the repair companies. So they had a true problem where their patients were not staying asleep, and it was a vaporizer problem. So even though she had the vaporizer set at 2%, it was only delivering, I think, 0.8% when they tested it. It was really, really low. So even though it said 2, was not delivering 2%. So keep that in mind. That's a very significant finding. The only thing that was on there that I said what was not a reason was expired soda lime. Soda lime is not going to affect your patient's anesthetic depth. The only thing the soda lime is going to affect is your patient's CO2. So soda lime and vaporizers don't have anything to do with each other. I have, what are 2 things that you can troubleshoot if your patient is not staying anesthetized? Now, anytime I ask you a troubleshooting question, a good anesthetist develops an analytical mindset. So what do? Okay, I look at my vaporizer. Do I have anesthetic? I've had students forget to put anesthetic in the vaporizer, and your little thing in the vaporizer is empty. Do you have oxygen flow? Is it hooked up properly? Is your endotracheal tube connected? And the other thing is, Yeah, as you do have a leaky rebreathing bag, I don't know if you remember, I mentioned in, sorry, I gotta type something here. Um, I mentioned in our lecture that those rebreathing bags tend to get leaks around the top where you hook up the bag to the machine. And sometimes they're tiny little holes. If you have anesthetic leaking out of that bag, and sometimes you can't smell it, that would be a reason that your patient is not getting enough anesthetic. It could be a leaky bag. So check your bag, check for leaks, make sure everything's checked up. If you've checked all of that, then maybe you need to call the company like my friend did and have them come out and actually, and then they can check that. So let's see. Which of the following is not an indicator that your patient is too deep? So your choices were systolic below 80, that patient's too deep, bradycardia, too deep, dilated pupils, too deep. The only one here I had jaw tone moderately tense. Okay, so obviously if they're too deep, their jaw tone's going to be extremely loose. So if they're starting to get tense jaw, they're starting to come out of anesthesia and actually get light. But remember, eyes, the good position should be ventral medial. They should not be central. Now, you don't want jaw tone during surgery, but they should be loose during surgery. Shouldn't have a blink, shouldn't have withdrawal. But if your heart rate is continuing to drop, hopefully what you guys will notice is that when you first take their heart rate, say it's 120, you just anesthetize them, then it starts to go 110, 100, 90, 88, 87, 89, 86, 82, 91. Do you see what happened? It went down, but then it kind of leveled. And that's usually happens in the first 20 minutes. That's when the propofol wears off and the gas kicks in. You hit into a plateau. If you're continuing on a slope and it's continuing to go 89, 76, 72, 68, 61, 57, you see where I'm going? I'm just going, you got to turn that patient down. Obviously, look at all your other values. Most of the time, other values are going to support that. The eyes are going to rotate central, respiration's going to drop. So have to be careful. One or two things to do immediately if you think your patient's too deep, if you're really concerned, then you need to, number one is I usually turn down the vaporizer. And if you think they're too deep, you can actually, normally I say don't hit the flush valve during a procedure, but if they are too deep, you can disconnect the patient, hit the flush valve, and that will dilute out the anesthetic in the system. And by giving them more pure oxygen, it's going to naturally dilute them out. It should lighten them up. If we're in danger deep, you can ask the doctor if they want you to reverse drugs. You guys are going to be using dexdomitor. It's reversible. You can reverse them. Reversal works the best 45 minutes to an hour after they received it. If it's after that, sometimes it's already worn off and that's not the cause of the problem. But we will always reverse an animal we think is in trouble. You can increase fluids because if they're deep and their blood pressure's low, that'll help dilute out intravenous agents or agents that were in the muscle that can help. Which of the following is not a reason for pale mucous membranes? So the right answer's anemia is pale. And I classified in lecture, were they anemic to start with, or are they losing blood during surgery? So you need to have that answer. Were they pale when you started? Hopefully, if you started with a pink patient and now they're pale, it's a surgery problem. If they started pale, why were they pale when you began? Um, Hypothermia will cause pale mucous membranes and blood loss during surgery. The only reason on there was hypertension. That is not hypertension, or high blood pressure sometimes will cause a bright red mucous membrane or pinker than normal. So normally hypertension will not make them pale. Which of the following drugs often causes pale mucous membranes? Hopefully, because you guys have been radiology, it was dexmedetomidine. And it's dexmedetomidine because it causes a massive peripheral vasoconstriction. And so all of the little vessels in the gums constrict. Therefore, there's less blood in the gums. Therefore, they look pale. So if I have a pale patient and I look on my sheet and I go, we gave dexdomitor, I'm like, that's probably why. If I did not use an alpha 2, most other anesthetics will not cause paleness like dexdomitor does. So then you have to start, are they cold? Do they have low blood pressure? Okay. You notice your patient is dyspneic during anesthesia and their color is cyanotic. What's 2 things that you can do to reverse the problem? So the only thing I want to see on here is something that has to do with oxygen. Fluids. Right now, this is a breathing problem. So 2 things that I can do to treat. Well, first of all, I have to verify I have oxygen. I have to verify that it's running. And I have to verify that there's not a plug or a kink in my endotracheal tube, and make sure everything is hooked up. If you hook up your machine wrong, you can have a cyanotic patient. You can have a patient that cannot get oxygen. So you have to verify that everything is correct. Now, the most immediate thing to do is try to bag the patient. You can turn them down, because if you turn down the anesthetic, they might not be breathing well because they're way too deep. And maybe they're getting cyanotic because they're not breathing because they can't, because they're too deep. But usually bagging and turning down your anesthetic, verifying oxygen. It's very rare an animal should be cyanotic during anesthesia because they're intubated, they're on an anesthetic machine that has pure oxygen. So we have an airway. There really shouldn't, where's the issue? Do you see what I'm saying? It should be fairly easy for them to breathe. Do you have the wrong size tube? Do you have the wrong size breathing system? Apnea is permanent cessation of breathing. That was false. Apnea is temporary. Respiratory arrest is permanent cessation of breathing. So apnea can lead to respiratory arrest, but a lot of times apnea is transient. It happens after propofol. It happens after alfaxin. So sometimes we just have to get them breathing again. But there is a difference between respiratory arrest and anemia. One reason for apnea post-induction is from propofol. That's true. It's probably one of the #1 side effects next to hypotension. Those are the 2 things I worry about with propofol, is low blood pressure and apnea. Apnea I can control. I can put a tube in, I can bag them. The apnea should go away within about 5 minutes or so. Low blood pressure, I would just have to make sure they're on fluids and try to keep their anesthetic low till their blood pressure comes up. You believe your patient is apneic during anesthesia. What are 2 things you need to do immediately? Okay. When I first notice that they're apnea, I want to check a pulse right off the bat, because if they're apneic and it's going to be respiratory arrest, is their heart rate super low? Am I in danger of their heart stopping? Now, if I have a nice normal heart rate and I have a good blood pressure, the apnea is probably from other reasons. But if I have low blood pressure, low heart rate, apnea, I could be too deep and I could be heading to cardiac arrest. What I need to do is verify, I need to bag the patient, turn down the anesthetic, verify, just like I said, is everything hooked up? Do I have oxygen? Alert my doctor. But immediately what you need to do is you need to verify your other vitals to make sure that it's not like everything is heading in one direction. Vagal stimulation will cause immediate tachycardia. That was false. It's bradycardia. One type of arrhythmia you might notice, you could have put VPCs, heart block, tachycardia, fibrillation. Those are probably the most common arrhythmias we see associated with anesthesia. We probably tend to deal with more bradyarrhythmias than we do tachyarrhythmias for the most part. Okay, are there any questions? That was the whole test. Like I said, I'm going to go through and finish the grades here this afternoon. But in the meantime, are there any questions? And one thing to bring up, and you can actually say something if you want or whatnot. And maybe some people have been told this, but I know that Miss Gray does not have you guys. Miss Gray is leaving at the end of this term. She's going back to private practice. So next Friday will be her last day. She is not in on Mondays, but she is in the building on Tuesday, Wednesday, and Thursday, and you probably know that Zuber's leaving. So I'm super bummed because they're two of my favorites, but I go way back with Aaron. Yes. Oh, okay. I thought Zuber shared that with you guys. Yes. So Zuber and Gray are leaving. Ms. Zuber's actually going to VCA where I used to work, and Ms. Gray, she's going to a private practice. I think it's near Brownsburg or Lebanon, somewhere on the west side. I can't remember the name of the practice. So I'm trying to be happy for them, but I'm sad for myself. Yeah, I'm hoping they'll be happy. But, I mean, Gray's been there about, I don't know, she's 11 years, maybe 10 years. So she's been there a long time. Yeah. So she did want me to communicate that to you guys. I mean, her schedule's crazy, and you guys, it's not that she didn't want to tell you in person. She was just like, I have to find someone to tell them because she's running around, and certain days she's not in the building, and certain day you guys aren't in the building. So believe me, I know she wanted to have told you in person, but it's just difficult with the scheduling. So if you do see her next week, you might want to say goodbye. I guess Zuber will talk to you. I thought Zuber had told you guys. Yeah, we kind of had a mass exodus. I would be lying if I didn't say it crossed my mind. But I still like teaching enough that I'm going to try to stick around. But for the moment, I'm not. But at least you guys got to have them. Yeah, Miranda, I agree, but everybody's kind of teacher wise is about here right now. So they were here, I'm here. So I'm not quite there, but I get close. So it's a difficult, I don't think everybody would miss my stories or my dogs, but thank you. Um, it, I mean, it's a difficult job. It's a lot to balance. You know, teaching is, I still get a lot of enjoyment out of it, but you know, everybody reaches their point, and some people, you know, when you do what we do for a while, you miss being a tech. You miss putting in catheters and drawing blood and being the one doing it. You know, we're teaching you how to do it, and sometimes you want to be the one doing it. I mean, I still pick up shifts at VCA, so I still get my feet wet enough. I still get to be a tech um, enough right now to balance teaching, and like I said, still have a little side job um, that keeps me busy on the side. So I think I still get enough of the tech world to also remember why I left that side. So right now, it still works for me, but yes, everybody has to do what they have to do. And I think she's looking forward to a change. So make sure you guys maybe bop in and say bye. Um, yes, yes, Zuber's going to be at the VCA in Fishers where I still do some work. So here and there, it's nice to do a little what's called PRN as needed. So yeah.